the subepithelial connective tissue graft to cover root surfaces. The code number of this patient is 2173. The learning objective is how to learn the principles of connective tissue grafting, the healing sequences of the donor site, predictability and longevity of the connective tissue graft, and the creeping attachment phenomena with a follow-up for 15 years. This case presented in 1999, complaining from severe recession of his upper left canine and first premolar. He was also aware of initial recession of the upper left lateral. The decision was made based on the receding condition and the lack of attached gingiva to proceed only for the upper left 3 and 4 for the subepithelial connective tissue graft in order to cover the root surface and create an attached gingiva. A partial thickness flap was raised by sharp dissection, leaving the periosteum and partial connective tissue over the periosteum, as you can see it here on the upper right slide. The crestal bone level was further apical than the level of the original mucosal soft tissue margins before raising the flap. A subepithelial connective tissue was harvested from the palate and sutured with the flap at the most coronal level up to the cemento-enamel junction. The flap, vertical sutures, and the papillary sutures were included in the graft from the sides and from the middle interproximally to provide stabilization of the graft and avoid mobility that could endanger the anastomosis of the blood supply of the graft. Sutures of the donor site were made all along the vertical and horizontal incisions. The vertical incisions were made to provide maximum accessibility in order to harvest the maximum size of the connective tissue graft, as we needed enough width to cover these wide surfaces of the exposed roots of the canine and the first premolar. Looking at the upper right slide, after 1 week post-operative, you can see the sloughing of the flap at the palatal area, at the incision lines, as the edges of the flap were not completely sealed together. And in 2 weeks post-operative, you can see the sloughed area healing with the epithelium creeping over the connective tissue exposed area. And in 3 weeks time post-operative, one can see a complete seal of the incision line covered completely with epithelium except at the very end of the horizontal incision line. This series of slides show in 1999 the severe recession of the gingiva with loss of the attached gingiva, using the cervical margin of the second premolar crown as a stable landmark. One can notice if we draw a straight yellow line at the CEG level, the amount of recession that has been existent 15 years ago. In 2 months' time, post-operative, you can see the formation of the attached gingiva, which was missing, and the blending of the keratinized tissue right here with the mucosa apically, without any demarcation or scar line, and of course some degree of root coverage. In 9 months post-operative, you can see the amount of creeping of the attached gingiva covering the root surface, and the increase of width of the keratinized tissue without still any demarcation line with the mucosal tissue apically, as you can see it here. After 15 years follow-up, you can see the gingival margin almost at the level of the CEG, with full keratinization of the gingiva. And if you compare the yellow drawn line from the cervical edge of the crown, using it as a standard landmark distally, and the midway from the papilla height on the medial side of the canine, one can see the progress of the creeping attachment phenomena 2 months and 9 months post-operative, and all the way 15 years. You should also note that the gingival margin of the upper left lateral did not change along in 15 years and maintain the same level, if not better.